Next topic that we need to more fully address is the anatomy of the ear, the peripheral auditory apparatus, and utilizing or beginning here, visualize how the brainstem processes cochlear or vestibular nerve information. So what's shown on this picture is the basic anatomy of the ear, beginning with an external auditory meatus that's lateral to the tympanic membrane. That's the external ear. The middle ear contains the ossicles, which, as we'll see in a moment, we'll name them, and their job is to amplify sound, step up sound pressure levels. So note that both the external and the middle ear are air-filled channels, the middle ear being connected to the nasopharynx by the auditory or the eustachian tube. The inner ear is an environment that is fluid-containing only, and that's certainly where we find the hair or the receptor cells that are responding either to cochlear or vestibular kinds of input. So what's shown on here is the cochlea. Basically, it's coiled up. The base of the cochlea is at B. The apex of the cochlea is indicated by A. And now we're going to look at a cross-section through one of the turns of the cochlea to visualize what the auditory receptor apparatus looks like. So this view is on the next slide, and what you can see is that the actual cochlea contains two different fluid environments. In the middle, or what's known as the scala media, that's a synonym for what's known as the cochlear duct. And the cochlear duct contains specialized hair cells that are found in the organ of Corti. And those hair cells that make up the organ of Corti are situated on a highly flexible basilar membrane. And because of the nature of the basilar membrane and its distance from the middle ear, the frequency response characteristics of the basilar membrane change along its length. So note that the frequency response characteristics at the base of the cochlea, where the basilar membrane is the narrowest, they are where we find the high frequency response hair cells, whereas hair cells at the apex of the cochlea are responding to the lowest frequency sound pressure generation. So on either side of the scala media are two fluid-filled environments, each containing perilymph, whereas the fluid environment that actually bathes the hairs of hair cells is one which is formed by endolymph. And endolymph is a specialized extracellular fluid that's produced by a specialized epithelium in the adjacent wall of the cochlear duct known as the stria vascularis. When we have an auditory problem, basically the patient can either have a conductive hearing loss or a sensory neural hearing loss. And the difference is the following. If the patient has a problem in the external ear, blockage, wax buildup, or a problem in the middle ear, otitis media, otosclerosis, those locations will be causes of a conductive hearing loss. In contrast, as we'll see, if we lesion any neural component of auditory processing, beginning with organ of Corti hair cells and any of the central auditory projections, that will be a cause of a sensory neural hearing loss. And there are two tests, basically, that are used to evaluate the lateralization or the side of a hearing loss. One is the Weber test. Weber test utilizes a tuning fork that is placed in the midline, usually at the vertex of the skull or at the bridge of the nose. And what the Weber test does is it localizes basically where there might be a problem. But here's the interesting point. If a patient has a sensory neural hearing loss on one side, it's logical to assume that the vibratory sense of the tuning fork will be perceived better in the normal ear. But in contrast, if a patient has a conductive hearing loss, the vibrations of the tuning fork will be perceived louder on the side of the loss. Because it turns out that under normal circumstances, bone conduction partially interferes with air conduction. So if you eliminate air conduction in a patient with a conductive hearing loss, they're going to perceive the vibrations louder in the affected ear. Then, knowing that the Weber test only lateralizes the hearing loss but doesn't tell you which kind it is, the next test might be to perform is the Rene test. And this is a classic test for the presence of a conductive hearing loss. And here's the way the test works. Bang the tuning fork and place the tuning fork on the mastoid process. And obviously now the presence of the tuning fork in the mastoid process is bypassing the middle and the external ear, so you're perceiving the auditory vibrations using only bone conduction. So you ask the patient to raise their hand when they no longer perceive the bone-borne vibration, and then you move the tuning fork away from the mastoid process, adjacent to the external auditory meatus, where the patient should then rehear the vibrations of the tuning fork, because under normal circumstances, air conduction is always better than bone conduction. If there is no air conduction after the bone conduction, that's a class of positive sign that the patient has a conductive hearing loss. But as we said, if the patient does again hear the vibratory sense after removal from the mastoid process, if air conduction is better than bone conduction, that basically means that there is no middle ear problem, and depending on the extent of the deficit, that might indicate basically that there is a sensory neural hearing loss on one side versus the other. Next, we pointed this out a little earlier. What are some common hearing problems? Well, certainly common causes of a conductive hearing loss could be a middle ear problem, otitis media and otosclerosis being common ones, or a wax buildup or blockage in the external auditory meatus as well. So note that hearing problems can also emanate from the facial nerve in the form of hyperacusis, an increased sensitivity to loud sounds. And bear in mind the difference between a patient that has hyperacusis versus a patient that has presbycusis, that's known as old hearing, where we progressively have a tendency to lose hair cells at the base of the cochlea and have a progressive loss of high-frequency perceptive abilities. Next, let's look at kind of a phantom view of the overall extent of endolymph and paralymph, the two different fluid environments that make up the entire inner ear, not just the cochlear duct. And what we're seeing in this picture is the dark shaded areas represent the fluid environment inside the epithelial components of the inner ear, and this is where we find endolymph. Note that literally, as shown here, the cochlear duct is a linear tube of endolymph, and where the hair cells are located, the scala media. But note that endolymph is also bathing hair cells in the various vestibular receptors. The ampulla contains an ampullary crest that is responding to angular acceleration. The utricle and the saccule contain patches of hair cells that are responding to linear acceleration, or helping us maintain upright posture relative to changes in the body position relative to gravity. But note the difference. Endolymph is unique with regard to an extracellular fluid because it kind of has a backwards inorganic ionic composition. Because certainly a typical extracellular fluid has a high sodium ion concentration relative to a low potassium ion concentration, but endolymph is the reverse of that. The stria vascularis produces endolymph, an extracellular fluid that has a high potassium ion concentration and a low sodium ion concentration, and this concentration differential is essential for hair cell function. The additional feature that's shown on this slide is we have named the three ossicles that are all linked together by way of synovial joints, and their job is to step up sound pressure levels, mainly by concentrating sound that's impinging upon the large surface area of the tympanic membrane and concentrating it down onto the surface of the stapedial footplate, and in providing that mechanical advantage to step up sound pressure levels and amplify the sound waves. Now, the next thing we want to do is look at the various auditory structures inside the CNS that are involved in the transmission of audition to conscious levels of cerebral cortex. And down at the bottom right of this picture, we can see certainly that a cochlear hair cell is being innervated by the cochlear nerve fibers, whose cell bodies are spiraled around the cochlea in the spiral ganglion. And as we know, the entry point of the cochlear nerve into the brainstem is entering at the pontomedullary junction, where all of the incoming cochlear nerve fibers from the entire cochlea basically are going to synapse in the cochlear nucleus. Then, above the cochlear nucleus is the superior olive. And as we said earlier, the superior olive is the first site where neurons are being driven bilaterally by both cochlear nuclei, because the superior olive is the first site in the CNS where we have neurons that are being sensitive to sound localization and not just auditory processing. So beginning at the level of the superior olive and at every point above that, all of the auditory structures are not only conveying a sound stimulus to conscious levels of cortex, they are also going to participate in sound localization. And the outflow of the superior olive courses up into the midbrain from the pons in the lateral lemniscus, synapses with neurons in the inferior colliculus. Then from there, the inferior colliculus projects to the thalamic auditory relay nucleus, which is the medial geniculate body, and the medial geniculate body then projects up to primary auditory cortex in the upper part of a temporal lobe. But here's the point again, the differential. What's going to be the difference in a lesion at the level of A, which might be a lesion either to the cochlear nerve or to the cochlear nucleus, versus a lesion at any point above the cochlear nucleus, and the example we give is a lesion at the lateral lemniscus. The difference is, if I have a patient with a lesion at A in the cochlear nerve or the cochlear nucleus, the patient will have a profound ipsilateral sensory neural hearing loss. In contrast, any lesion to any auditory structure above the cochlear nucleus, beginning at the level of the olive or higher, that patient is not going to have an ipsilateral hearing loss. They're most likely going to have a slight bilateral hearing loss and a decreased ability to localize sound. So again, remember the differential between a lesion at A versus a lesion at B. And that point is made in the clinical correlate on the next page, where again, if a patient has a profound ipsilateral sensory neural hearing loss or a profound hearing loss, you know that the lesion can be no higher than the cochlear nucleus. Whereas if a patient has just a decreased ability to localize sound and maybe a slight bilateral hearing loss, the lesion site could be at many locations, the olive, the inferior colliculus, the lateral lemniscus, the thalamus, or even the cortex. Multiple lesion sites could be a possible cause of a bilateral hearing loss. The next topic we want to deal with is how the brainstem and higher centers utilize vestibular information generated by either the macular receptors in the utricle and saccule or the angular acceleration receptors that are found in the semicircular ducts. So, like the cochlear nerve, the vestibular nerve that innervates those hair cells in those various regions enters the brainstem at the level of the pontomedullary junction. And the vestibular nerve fibers synapse in an array of 4 vestibular nuclei. And one of the functions of those nuclei is to maintain upright posture relative to gravity by providing a source of upper motor neurons in what's known as the vestibulospinal tract, which goes down and enhances the function of anti-gravity muscles, in essence, to help you maintain upright posture. So that's the central processing that's utilizing linear acceleration input generated from macular hair cells in the utricle and saccule. Of additional interest is the wiring mechanism that utilizes vestibular input that manifests itself as the vestibulo-ocular reflex. So basically, this reflex is generated when you want to maintain an object fixed on the fovea of each retina when the head turns. So in our little example here, we're going to have a hypothetical head rotation to the right, and we're going to generate a vestibulo-ocular reflex in response to that directional head turning. So here's how it works. When you rotate your head horizontally to the right, you stimulate the vestibular labyrinth on the right, and as a result, the vestibular nerve. So when you rotate your head horizontally to the right, the first thing that is stimulated is endolymph flow in a direction that stimulates hair cells on the right. And if you stimulate hair cells on the right at number 2, you're going to increase the firing rate of the right vestibular nerve. And logically, number 3, you're going to also stimulate the firing of the right vestibular nuclei. So it's going to be the job of the vestibular nuclei to send axons out largely through the medial longitudinal fasciculus to make both eyes look to the left in response to a horizontal head turn to the right. And that's exactly what happens. But recognize certainly which cranial nerves have to be activated. In order for both eyes to look left, we have to abduct the left eye. So fibers have to cross the midline out of the vestibular nuclei and go over to the left abducens nucleus so we can abduct the left eye. But then that same medial longitudinal fasciculus has to go up on the right side to stimulate neurons in the right ocular motor nucleus so I can simultaneously adduct the right eye. So the net effect is when I rotate my head horizontally to the right, both eyes will reflexively look to the left to keep an object of interest focused on both retinas. But now the clinical correlate. What might we see in our example if we have a lesion of the left vestibular nuclei? Well, when you have a vestibular nucleus or nerve lesion, patients are likely to present with dizziness, nausea, vomiting, and balance problems, but they may also present with a vestibular-evoked nystagmus, And here's how the nystagmus basically works. Because we have a lesion in this example of the left vestibular nuclei, basically they've been taken out of play. And by default, because you've disrupted the neurologic balance between the vestibular nuclei, if we have a left side lesion, in effect you've artificially stimulated the right vestibular nuclei. And recalling back from normal anatomy, what happens when you stimulate the right vestibular nuclei? They cause the eyes to look slowly to the left. That's obviously their job in the VOR. But what happens in this case, because there's a lesion, the cortex realizes that the head did not turn, and in response to a slow deviation of the eyes to the left, the cortex corrects for the slow deviation by generating a fast phase or corrective phase of a vestibular-evoked nystagmus. So a nystagmus always has two components. It has an initial slow phase that's really the result of the pathology, and assuming that the cortex is still connected to the brainstem, there will be a fast or corrective phase in the direction opposite of the slow deviation. And it is always the fast or corrective or secondary phase that defines the nystagmus. So in our example here, as we'll see text-wise in a minute, if we have a lesion in the left vestibular nuclei, the fast phase of the vestibular-evoked nystagmus will be away from the side of the lesion, in this example, to the right. And that's exactly what's illustrated in the clinical correlate on the next page. A lesion of, in our example, the left vestibular nuclei will cause a slow deviation of the eyes toward the lesion, in this case the left, and a fast or corrective phase away from the side of the lesion, back, in our example, to the right. As we indicated earlier, it's the cortex that is generating the fast or corrective phase of the vestibular-evoked nystagmus, assuming that it is still connected to the brainstem. The next slide simply illustrates the same phenomenon as our lesion. In our example on this slide, there is a lesion on the left side, as was the case in our example, that initially causes a slow deviation of the eyes to the left, the figure at the top of the slide, and a fast or corrective phase away from the side of the lesion, in this case to the right, assuming again that the cortex is still connected to the brainstem. The other feature that's worthy of note is there is a way to test the integrity of the vestibulo-ocular reflex and use this test as an overall kind of gross view of brainstem function in an unconscious patient. And this is the value of the caloric test, where you are introducing cool or warm water in an external ear, and assuming that the VOR is still operating, you should generate a caloric evoked nystagmus in a certain direction, depending on whether you're utilizing cool or warm water. And here's how it works. Cool water basically mimics a lesion, meaning that if I put cool water in an ear, there's going to be a slow deviation of the eyes toward the cool water side and a fast phase of the caloric evoked nystagmus away from the cool water side, analogous to a lesion. Because cool water introduction into an external ear cools down the endolymph on that side and in effect mimics a lesion. In contrast, warm water calorics stimulate the side that you put the warm water in. So if I put warm water in an ear, in essence, I'm going to stimulate that vestibular labyrinth. The eyes will deviate slowly away from the warm water side, and the caloric evoked nystagmus will be back to the same side where I put the warm water. And this gives rise to the little mnemonic word COWS, cool, opposite, warm, same, which is expressing the predicted direction of a nystagmus, either away or toward a corresponding ear in response to either cool or warm water caloric stimuli. Again, and the last point that's made on this clinical correlate slide is other auditory or ear issues involve, if it's a vestibular lesion, the patient might have various forms of vertigo, the perception of rotation. It's usually much more severe in a peripheral nerve lesion and usually much less significant in a brainstem lesion. But if it turns out to be chronic, even though mild, it suggests more of a central lesion. Meniere disease basically is characterized by abrupt recurrent attacks of vertigo. And Meniere disease basically is caused by a disruption or alteration in the flow, production, and absorption of endolymph. And typically, not only is a patient commonly going to develop vertigo, a patient with Meniere's disease, and it affects all of endolymph flow and or absorption, patient may have ringing in the ear, tinnitus, deafness, and dizziness, nausea, and vomiting may also accompany the signs and symptoms associated with vertigo.